Okay, so once again, I am Dan Warrender in a room by myself, talking to myself, this time about psychotherapeutic and social interventions for mental health issues. Do what you need to do throughout this, you know what I mean? Pause it, take breaks if you need to. I'm reckoning I'll probably be talking for about an hour. It's hard to tell once I get going. So, and yeah, I mean, maybe worth saying at the start as well, it's one of the real difficult things in doing it this way is that I don't get to attune to you guys' kind of mental states, so I don't get to see faces in the room and like see when people look confused, when people think things are funny, when people look uncomfortable and stuff like that. So I guess it's difficult for me to meet the needs. I guess your learning needs because I'm not there. So if there are any questions, anything that you're unsure of, anything you want to speak about, then just give me a shout. Okay. So what we're going to do. So we'll think about some psychosocial and psychological therapeutic interventions. We'll explore some of the evidence base for psychotherapy and going to emphasize the key ingredients of good human interactions. And it's worth saying as well that as well as being a lecturer at RGU, I still work at NHS Grampian on an honorary contract as a mentalisation-based therapist at the psychotherapy department there. That's something I've done since I've always kind of done that when I've been at RGU, just kind of in my own time. And I think that's probably one of the most important things that I do as a human being, and I'll probably continue to do that long after whatever I'm, I don't know, fucking, you know, you're thinking out loud and you're just like brain farts. But I'm gonna let you see. I'm gonna let you see it all. I'm gonna be congruent. Yeah, no, I think I'll do that long after I've done anything else. So even when I'm done at RGU, I think I'll still do psychotherapy because I think it's a really good thing to do. So I'll use some of those examples from clinical practice throughout as well. Okay, so interventions. What are we thinking about? I think it's always a good philosophical thing to do at the start. Is thinking about defining your terms. So interventions, the action or process of intervening, action taken to improve a medical disorder. I know we can certainly kind of query whether things are disorders, but certainly action taken to improve the way people kind of think and feel. It's becoming intentionally involved in a difficult situation or a means of interfering with the outcome or course of a condition or process, so preventing harm. So bringing these things all together, it's essentially you coming together, coming between to interrupt a person from their distress. Is there any way we can get in between the person in their distress and help? Now, I'm not talking about medication, but I couldn't really resist a little bit of I guess the context around mental health care. Medication is the kind of sort of the go-to treatment for a lot of mental health issues. I don't necessarily think that's right, and I guess I just want to kind of plant some seeds that might raise some questions about why the medication is the kind of go-to thing all the time. So it's the most prevalent form of intervention, and it's unlikely for anyone diagnosed with a mental health condition not to be prescribed medication. It's got powerful effects on the central nervous system, and then main groups are antidepressants, antipsychotics, mood stabilizers, and tranquilizers. Okay. What I just want to the seed I want to plant with you guys is that medication may be oversold. So it might be something that we are almost kind of overemphasizing how useful it can be. And I'm not knocking that medication can be really helpful for a lot of people, but I think we maybe oversell how helpful it can be at times. So this guy, Eric Maisel, writes about psychiatric and anesthetic. He says it's basically an argument about how we use language and abuse language in this context. So talking about anesthetics that relieve pain, for example, paracetamol, and that's distinguished from drugs that are used to treat specific conditions or ailments. So we could think about the difference between being treated, which is sort of got a curative kind of connotation, to being anesthetized, which is kind of just having that sort of pain relief. So what Mazel's arguing is that when something's sold as an antidepressant, an antipsychotic, a mood stabilizer, when they're sold as medicine, we're essentially overselling it, because these are not curative things. Now, psychiatric medication can absolutely help to kind of dampen down symptoms, and I think it can be a really important part of somebody's overall kind of treatment plan. But I think if we look at these things as just kind of like, all right, take some antidepressants and then you'll be fine. Well, it's never enough without looking at kind of what's going on in a person's life and then thinking about other things that might help. So the belief that these things are curative exists through their labeling as medications and not anesthetics. And another thing that he argues is that, like, I guess argues against the chemical imbalance theory, which has been kind of, I guess, asserted but not kind of proven. And he says that what medications do are that they are powerful medications, powerful chemicals with effects. So he says when somebody is feeling the benefit from a medication, it's not that it's correcting a chemical imbalance, it's just creating a new state. So imagine you take any kind of drug, you know what I mean? You drink alcohol, drink coffee, take any kind of substance, it alters your mental state. And Mazel argues that that's what these kind of antidepressants, antipsychotics, that's what they do. They alter your mental state. They don't fix or rectify or cure anything. I couldn't resist that kind of sort of just planting that seed, because I do think in society we kind of we potentially look to medication as being the thing that's going to make everything better, and I think that can make people feel hopeless. You know what I mean? If people have got a diagnosis of depression, experiencing low mood, they get antidepressants, and then they're still not feeling great, you know what I mean, after 6 weeks or whatever, then people might lose hope. But then I would be arguing that, like, as well as medication, then you need to be thinking about, like, who are the people that are around you in your life, what other kind of things can you do. Okay, so I'm going to rattle through a few different kind of interventions and then spend most of the time on psychotherapy. So peer support, bringing together people with shared experiences to support each other. And that's one of the reasons that I said that kind of diagnosis can be a kind of helpful thing in some ways, in that it groups people together that have a shared label, potentially some shared experiences, and that can help people connect with each other. Remember, there's also kind of lots of kind of pitfalls and negatives to diagnosis, but that's probably one of the strongest things for it. So it can provide a space where people can feel accepted and understood, treats everyone's experiences as being equally important. I think that the next bit that involves both giving and receiving support is a really important thing, because actually through helping other people, we help ourselves. I know that through doing psychotherapy and even through supporting students and stuff, sometimes I get an enormous kind of sense of kind of, I don't know, self-worth, value, meaning, and that's really, really important for me. So if people are going to peer support groups, then not only do they get a chance to kind of tell their story, to be accepted by people that have kind of had similar experiences, but they get the opportunity to help other people. And helping other people is, I mean, for me, like, you struggle to find greater meanings of being alive than helping others. So there's that kind of dual role of peer support there. And it also lessens the power dynamic that might be experienced with professional support. Remember, as a professional, there is a kind of power dynamic when you're working with people. And if people meet as peers, then it sort of takes away that power dynamic. People feel like they are kind of meeting on a level playing field. I mean, there can always be power dynamics in kind of different relationships, just interpersonally, but at the very least, the peer support takes away that kind of formal power dynamic. Okay. So social prescribing. There's been arguments as well about social prescribing, and are we actually trying to make something appear medical when it's not by using the word prescribing? And we could maybe think that, is that got something to do with the predominance of the medical model, that things I guess we can't imagine that they're legitimate without that medicalized bit of it. So social prescribing links patients and carers with non-medical sources of support in their community. Peer support might be one of those things. Recognises that health is determined primarily by social, economic and environmental factors. So if you think back to the kind of power threat meaning framework, that kind of stuff, the biopsychosocial model, thinking about all the factors that can contribute to mental distress, and that these are not always kind of medical kind of disorders like brain diseases. That's not the best way to think about these things. Most things can be understood in terms of what's going on in a person's life, what's the environment around them. Supports people to take control of their own mental health, and some examples might be volunteering, art activities, mindfulness, gardening, befriending, cookery, sports, yoga, etc., etc., etc. So there's tons of things out there. I mean, I'm saying there are tons of things out there. There's a lot out there. There's probably not a lot out there specifically for people that like identify as having kind of mental health issues. I think there's definitely been kind of, you know, I mean, funding cuts over the last few years. So some of these kind of really good peer support and socially prescribed kind of centres activities have kind of fallen away, sadly. But there's a lot out there, I guess, if you're willing to look. If you can be kind of quite creative, and I guess depending on what you like as well, that's the thing. And that's what the evidence base says around social prescribing. And like, I love it when an evidence base like points out the absolutely fucking obvious, but the evidence for the benefit of social prescribing depends on the degree to which people actually enjoy the activities that they're doing. So if you get like socially prescribed gardening and you hate gardening, well, that's not going to help, is it? So you have to be enjoying what you're going to be doing. I think that's really important when we think about maybe some of the therapeutic activities we might do with people in inpatient environments, for example. You know, I mean, I remember a kind of mainstay of therapeutic activity on one of our wards was arts and crafts and stuff like that. You know, I mean, you get a guy kind of in his kind of mid-30s that likes kind of, I don't know, rock music, and I don't know, it's just like a very different person. And I'm saying fucking arts and crafts, you know what I mean? It's like, it's not for everyone. So we really have to be thinking about what is available for people as individuals, and not looking for that kind of one size fits all. In the social prescribing stuff, that might be more of a challenge for rural communities. You know what I mean? What is available in your area? But I think that the process of just kind of becoming involved in something, doing something, it's potentially got that kind of that social connection element to it, and the mindfulness that can actually be in every single one of these things. So I mean, mindfulness is listed there, but you could garden mindfully, you know what I mean? You could cook mindfully. I mean, I think if I think about my most mindful moments when I'm just in the moment, not really thinking about anything else, really just focused on what I'm doing, it's probably playing computer games. And I think I don't get a lot of time to do it, but that's a bit of mindfulness for me. Psychoeducation. So the stuff that you're learning can be used in a kind of therapeutic way if you can help people potentially understand their own experiences, and essentially empower people. You know what I mean? I like the ideal for any kind of mental health nurse, or any nurse for that matter, is kind of to promote that sort of self-management, so that eventually, you know, I mean, nurses become kind of absolutely redundant. I mean, I don't think that's ever going to happen, but as far as possible, we want people to be able to not need our care. And equipping them with the tools to do that is really important. So as a nurse, you've got a role as an educator, but importantly, that's not just telling people the answers. Remember that people are in charge of their own stories, and that we might build shared narratives with people, and the psychoeducation that we provide can help people kind of bring some of the kind of theory into their story. So define as education with a person with a mental health disorder. Again, you'll see I don't like that word, but it's a lot of the language that's kind of used in evidence-based practice, etc. Seems to reduce relapse and encourage people to take their medication. Again, I think that I have to be really careful about how we're kind of using psychoeducation in that way. There's a lot of kind of varying evidence about the efficacy of medications. I guess a good example in antipsychotics would be that, so antipsychotics show some kind of benefit for people with psychosis, etc. But there's evidence from Europe, I think Netherlands and Scandinavia, that the longer people are on antipsychotics, the less well they do. And while some people that maybe don't take antipsychotics in the beginning, so they don't take them short term, their longer term outcomes can be better. So there's a lot of grey area around medication as well. So we have to be really, really careful that we are not showing kind of, I guess, one biased side of an argument, and encouraging people to take medication just because it's the kind of the status quo, just because it's kind of the done thing. Okay, I'll step down off my soapbox for a second and back to it. So in those receiving brief psychoeducation can have favourable results for mental state and social functioning. And again, we have to be sort of critical of these kind of evidence bases. I guess to give you an example of when I've used psychoeducation recently is helping someone that had experienced kind of horrific trauma, helping them through the shame of that as well. So people go through horrendous stuff, and then you think about what happens to you when you're terrified, when you're being traumatized. So you've got your fight, flight, freeze kind of threat responses. And even just that, even just having that knowledge can help people make sense of why they're in really difficult situations and why didn't I leave? Why did I stay? Why did I not run away? And you can help people make sense of that and let go of some of that shame by reminding them that it's a bodily response, it's an involuntary reaction that your body's essentially telling you that just stay still and you might get through it. Yeah. So it's a survival mechanism. It's a self-defense mechanism. So we can use things that we know to help people in a variety of different ways. So again, not about telling people the answers, but about using what you know, your understanding of theory, to help people make sense of their experiences. Arts-based therapies. I think these are really neglected, and I think, like, I look back to my training, and even the training that's probably offered to you guys now, and think that there's not enough of the arts in there, and I think that's a shame, because I think it's enormously valuable. And I do wonder if it's about the kind of the medical model stuff. You know what I mean? We look at things as kind of less legitimate when they're kind of arty, or, you know what I mean, they don't have the words prescribing in them. But I think about how art kind of I guess I'll use examples of myself here, because I remember certainly struggling emotionally as a young man, I think late teens and stuff like that, and going to the GP. And I'm really grateful to the GP for not just going down the route of kind of medication, but what he said to me was, like, I was an angry young man. He said, like, right, why don't you get a punch bag and then maybe, like, write down some of your thoughts and feelings. Now, that might be seen as, some people might think of that as dismissive. I felt like the guy's empathy, you know what I mean, the warmth and stuff, and he was genuinely thinking that, you know what I mean, medication wasn't the answer for me. The important part of that story is that, like, by writing, and then, you know what I mean, I learned to play guitar, wrote songs, blah blah blah. Like, that probably saved me in a lot of ways. I mean, like, I say saved, I don't know what would have happened if I didn't do those things, but certainly I looked to paper and pen for help with my emotional states for a number of years, and I do it less and less now, because I think I'm too busy to be fucking distressed a lot of the time now. But like, I still, it's something I still go back to. I still pick up the guitar and play it when I need to, and that, I think, I can't imagine medication helping me more than the arts have. Absolutely can't imagine that. So, arts-based therapies, what have we got here? So, not used as a diagnostic tool, as a medium to address emotional issues which might be confusing or distressing. Okay, so it's a way of working through things. It can be a mode of expression and communicating. Group or individual, and no previous experience of art is necessary. I remember speaking to an art therapist, and he was talking about a guy who's really not interested in the arts bit. And I guess, like, some of you guys might not think that you're arty people or you would be into it either. But he said that a guy spent ages looking at a blank bit of paper and then just put a dot on it and then just kind of step back. What the way their conversation went after that was him just asking the patient, the guy, what is that? What's that mean to you? And he said that was him. So this small dot on a big kind of empty sheet of paper just started to explore his feelings of being small, of being insignificant, and then working through stuff that way. So it's really about art being a platform to get in kind of conversations. And again, I think it's thinking about what are people's kind of preferences and what are the best ways of people to get stuff out there. Now, I mean, people say it's good to talk. It is good to talk, but I think it's just good to express. You know what I mean? So whether it's good to sing, to make music, to dance, I think these things have to be really, really subjective to people. And I really appreciate dance, like ballet and stuff like that. I really appreciate what people can do with their bodies and be so free, you know what I mean, so congruent with it, with their bodies and stuff. But I'm really not that confident in my body in that way. But I can be, like, when I like pick up a guitar and sing and stuff like that, I can be congruent in that way as well. So it's thinking about the best ways for people to tap into their own emotional states and what are people most comfortable with and what do they like again. Okay. So we spend probably most of the time talking about talk therapies. And again, I'll use some examples as they kind of pop into my head. So therapies are normally for groups or individuals. You've got your natural groups like families, stranger groups or group therapy, and then individuals one-to-one therapy. And there's benefits to each of these things. I mean, I think working in groups really helps you understand the mental states of other people. And that can be a really important kind of focus or aspect of therapy. One-to-one therapy might be really, really important because some things might feel too vulnerable to share in groups. And sometimes it's nice to have dedicated time where you're just with one person, where it's all your stuff that's getting explored as well. Now, therapeutic relationships are unique. And I think as nurses, we really see people across the breadth of human experience. Will experience real highs and real lows with people, and it's an opportunity to really, really connect. And I like this quote. So, the therapeutic relationship is like no other, in that service users may open up more than they have ever done with anyone else in their lives. It's absolutely true. So I've got close relationships with a lot of kind of family, friends and stuff like that. But the conversations that I've had with people in therapy, people have really laid themselves bare, and that's really an absolute kind of privilege to experience the trust that people will put in you to tell you these things. And I'm really, really grateful for that. But because of that, we have to really, really treat these relationships with an absolute sense of respect. You know what I mean? You have to really, really take these things seriously. When we think about relationships, there's content and process. So content is like the focus here, discussions. So models might be used to give a conversation edges. You know what I mean? What kind of therapy are you using, etc. But the process, so the therapeutic relationship and the how it happens, that's actually kind of argued to be the most important bit. And so if the process is the most important bit, then it means that any of us can be therapeutic. It's not just about, oh, I don't know a model, I don't know CBT, I don't know MBT. Well, that doesn't matter, because the process is the most important thing in helping. Okay. So, like I was saying, it's not all about specific therapies. There are over 500 documented therapies out there. There's almost no kind of clinically meaningful differences in how effective these things are. You're not seeing a new therapy come out and say, oh, this brand new therapy came out, we researched it, but actually it's shit. Like, it's not happening. All therapies are showing some kind of benefit. So we have to start thinking, what factors are what are the common factors? You know what I mean? What are the common factors to the process that are tying all these things together? Why are they all effective in some kind of way? So some of the evidence that's coming out about common factors, and that's a kind of an area of research for people now, is the common factors to psychotherapy. And these are all from kind of meta-analyses, so a synthesis of a large amount of of evidence. So a lot of different studies pulled together. So essentially, the more we do these things, the better outcomes will be. So the more empathy we show, the more positive regard for people, the more genuine we are, the more we express our own emotions, and the strength of the therapeutic relationship. Now, I'll talk about some of those things in a bit more detail as we go. But just to say, there is some evidence out there for these kind of common factors. Although we have to think really carefully again about the evidence base for psychotherapy research, because it's a difficult thing to research. So for a start, studies are often groups of people with the same diagnosis, but people are so unique that that might not be useful. Okay, so remember, you can get a really kind of heterogeneous group of people that are very different, but they've got the same diagnosis. So you're not starting off with the same exactly the same issue, because it's human experience rather than a kind of medical disorder. It can't be tested objectively. So you're starting off with a bit of uncertainty, a bit of grey area in terms of where is everyone at the start of their psychotherapy? You know, I mean, who are they as a person? What's going on for them? There's a replication crisis. Now, I think this is the same in terms of kind of psychiatric medications as well, but a lot of studies have got findings which can't be replicated. And that's a serious issue for the evidence base for kind of mental health care. And that's something that really, really needs explored over the next few years. Factors outside therapy might influence how well people do. Now, I think that's a really important one as well. So I've worked with people before where we think that, right, okay, they're kind of, they've definitely made a shift here. You know what I mean? They're kind of seem to have a shift of thinking. They seem to have a bit more self-esteem. They seem better in a number of ways. And then it'd be very easy for me to think like, this must be the magnificent therapy that I am giving them. But then take a step back again, think about, right, what's going on in this person's life just now? Right, okay, they've just changed job, so they're in a better job than they were before, and they've sort of become more secure in a romantic relationship. Those things might be more important. Like the therapy, I mean, again, I would love to think it's magnificent and that's doing everything, but that might be a bit of a footnote to everything that's going on in their life that's making people feel better. And evidence-based for psychotherapy is not good at kind of capturing those things, what went on in your life at the same time as having therapy. Some of the outcome measures might not accurately measure functioning or quality of life. So some of the early research into mentalization-based therapy was the outcome measures were that people would self-harm less and that there would be reduced admissions to hospital. Those might be very important things, but that's not necessarily measuring, but how do you feel? You know, I mean, people might not self-harm, they might not be admitted to hospital, but they might still feel like shit. So that's not necessarily measuring that kind of quality of life. So that's stuff we need to think about as well. The quality of a therapist is hard to capture, again, because we don't know exactly what are the sort of common factors, and patient participation can vary as well. So there's so many kind of dynamics in a kind of a nurse-patient relationship that it's really difficult to figure out exactly what works and why it works. Yeah, okay, so it's hard to generalize, so I've just made my next point already. I guess another point to make that I saw Peter Fonagy do a talk a couple of years ago, and he says that the differences between new and experienced therapists are actually not that statistically significant, but he was arguing that actually potentially more experienced therapists can do worse. And the reason he thinks that is that the more people that you've worked with, and probably particularly with diagnostic models, whenever you see a new person, you just think, oh, it's just another one of them. It's just another one of them. It's just another person diagnosed with BPD. It's just another person diagnosed with depression. And you actually lose that person-centered bit. So I think you could argue that being new and act genuinely experiencing people as human beings and not kind of diagnoses, not issues that you've experienced before, that's some of the important bits in terms of what we do. Okay. So, and I love what Yalam says, and I think that's a really important thing, that we should create a new therapy for each patient, and standardizing therapies can render them less effective. And I mean, think about, like, if you go for some therapy and it's just not quite working, would the best thing to do be for the therapist to continue doing what they're doing, or to think, this is not working, let's kind of change it? You know what I mean? Let's think of alternative ways where we can make some progress together. So and I think this is where, I guess, you guys as generalists, which is what you'll be, you know what I mean? And by generalist, I mean, when you guys are going to be out there working with people, you're not going to be specializing in any kind of particular therapy or anything like that. You're going to be working with all kind of a variety of human beings with a variety of issues. So actually the best thing that you guys can be doing is sort of pulling a variety of understandings, a variety of theories, a variety of models together, and just doing what kind of feels right with the person in the moment. So relationships are dynamic, and the therapeutic process is spontaneous. So actually manualizing things is not necessarily the best way to go. And if I even think about me learning mentalization-based therapy, I think it was a really useful framework, and I think I do rely on the framework to a degree. Sometimes I think it's, like I said, it's nice to have an edge to conversations, but the more experienced I've got, and the more I've taught and thought about these things, the more I've kind of sort of been willing to move away from it. The more I've been willing to stray from that model, and the more I'm willing to stray from that, I'm finding that I'm becoming much more person-centered. I'm much more responsive to the needs of people in the moment, and I'm not thinking about my agenda in terms of doing the mentalization-based therapy. I'm thinking about, what does this person need just now, and then kind of going based on that. So sticking to a manualized therapy is not necessarily kind of person-centered, and we need to be flexible with people. And that's a benefit to you guys not being trained in a specialized kind of therapy and at the start of your careers, is that you can be that generalist and you can pull together all that different stuff and just do what you think is going to work for people. Okay. Hopefully you're still with me. Feel free to pause for a minute if you're getting tired. I wish I could, but I honestly just like to rattle it out and get it done. It's the best way for me to work. So, remembering that we're all human beings is incredibly important. Now, that might sound really, really obvious, and forgive me if it does, but you'd be amazed how quickly people forget this. So patient and professional are artificial social constructs, right? And like, if you want to do a thought experiment, imagine that, you know what I mean, society collapses overnight. There's only a few people left. Like, imagine The Walking Dead, for example, or something like that. So it's just a group of people together, and you happen to find yourself in that kind of helping role. You're a nurse, you like talking to people, so you've formed that role in the group. Now, in that sense, it's probably easy to remember that you're just both human beings, and you know what I mean, you've got shared experiences, and that you're going to work through stuff together. But the more that we kind of professionalize things, and I think there are good reasons for professionalizing things, you know what I mean, that we've got professional regulatory bodies, etc. But that can kind of pull us away from remembering that the other person is a human being. So when we put on a uniform, we think, I'm a nurse, this is a patient. That can get in the way of just being, this is a human being in distress, I'm a human being that's going to try and help them. And it definitely pays to remember the humanity in each of us. And I like what Yalom says again. I totally recommend that book, by the way, The Gift of Therapy by Irvin Yalom. Describes professional and patient as fellow travelers. And I think if you walk into your interactions with people thinking that they are a fellow traveler, they're a fellow human being, that they are someone that, you know, I mean, you could be experiencing what they're experiencing just now. They could be a nurse. The only difference is they've maybe not just kind of not done the training that you've done. There's much more that connects you than separates you. So by focusing on kind of patient, we can other people, we can see people as different, we can see people as weaker, as less. So I would ask you to kind of take that conscious step back at times and just remind yourself that you're just kind of human beings in a room. And if you're remembering that people are humans, it can help you empathize, it can help you connect with their experience, it can help with that power dynamic, because remember that we do have a position of power over people. Sometimes we hold, like, we're the difference between people getting access to care or not. That's an enormous amount of power. And it can help with anxieties around sort of sharing some of yourself as well. If you just remember it's another human being, that can kind of take away some of that anxiety. So I'm saying that we're all humans, and we are. It's important to remember that, but remember that we've all got different stories. So misunderstandings will happen because we've all got different stories. Different things have happened to us. They've shaped the way that we see the world. And we've got a common humanity, but we've got a different script at times. And it's important that you don't necessarily think about the way that you see the world and think that everyone sees the world in the same way. People have a variety of different ways of kind of looking at the world based on their experiences, and social scripts might be very, very different. The difference between somebody generally trusting people or somebody generally mistrusting people might make perfect sense. You know, I mean, and thinking back to kind of trauma, for example, people that have experienced trauma, it's very sensible not to trust other people, because if you've been hurt by people that have been in kind of close relationships with you, then it's actually adaptive and a sensible survival strategy to not survive people, to not trust people. Okay, so remember that we've all got different stories. And be self-aware. Okay, so knowing yourself is incredibly important. I'll talk about mentalization in a little bit more detail in a second, but talks about knowing yourself from the inside. So thinking about what's going on for me. What am I thinking? What am I feeling? Where's that coming from? And then seeing yourself from the outside and thinking, like, how are other people experiencing me? Now, that's a really difficult thing for me to do just now, given that, like, imagining how people experience me is difficult because I can't see your faces. There's a bit of, like, I would have some information to go on. I'd be talking right now and I'd see people either nodding heads or being like, just looking like half asleep, or looking angry or bored or just laughing at me or whatever. But that would give me information in terms of how other people are experiencing me. So try and attune to that. So again, it's recognizing that the way that you see the world in a particular way, but your way is not the way. Yeah. And recognizing that things can be very different if different people do them. So if someone else was to do this lecture, this could be very different. So trying to kind of be self-aware of how is this coming across based on me as a human being. What am I bringing to this? Okay, now I've got nine things here, so 9 slides that I'm going to kind of go over, which myself and my colleague Scott McPherson have kind of been working on. I mean, it's I guess a bit of a living document. If we keep sort of coming back to what are the most important things in human interactions. Okay, so not just in kind of formalized psychotherapies. So these are ingredients that any person in the helping professions could use, and that we think would be useful. Okay, so I'll try and go through these and give you a basic understanding of them. Yeah, and like I said, like, I can't attune to if there's any confusion, but if there are questions, then feel free to get in touch. Coffee's cold. God damn. Okay. Now, mentalizing. Now, I'm talking about mentalizing as a process here. So mentalization-based therapy, that's one thing. It's not necessarily what I'm talking about here. Mentalizing is a social kind of process. We develop an ability to mentalize, to attune to others' mental states, and to understand their own mental state, often through primary kind of relationships with primary caregivers. So if you think about attachment theory, mentalizing has got its roots in secure attachments. So described as the human tendency to look beyond the visible shell of the body and understanding behaviors and seeking descriptions and explanations in terms of states of mind. Okay, that sounds like a very kind of complicated, convoluted sentence, but essentially it's saying focus on a person's mind, not their behavior. Okay, thinking about the thinking and the feeling that is behind behavior, not just behavior. So in short, there's no just behavior, as behavior is driven by mental states, so it all has meaning. Now, it really frustrates me when I hear it, and I hear it a lot, that, like, oh, person diagnosed with BPD or whatever, it's just behavior. And I hear that across environments, and I hear it in adult health environments and mental health environments as well. All across the board is actually non-mentalizing. So when we're thinking, oh, it's just behavior, then actually we are not mentalizing at all. We're not thinking about thinking. We're not being curious. Nothing's just behavior. You know, I mean, what's just behavior? What behavior exists without any need or mental state or thought or feeling behind it? People don't just randomly do things. So the idea that anything is just behavioral is bullshit. It's bullshit. So don't let yourself fall into that trap, because it's potentially an easy thing for people to do, because when it's hard to figure out what's going on for people, we just say, oh, it's just behavior. Just like punctuate that, full stop. I'm not going to be curious anymore. I'm not comfortable not knowing the answer, so I'll just kind of throw that in there. It's lazy and it's harmful as well. So again, I'll step back off soapbox, but please take that with you. So mentalizing involves self-awareness and other awareness. So it's seeing yourself from the outside. Okay, remember when I was talking about the self-awareness bit, but actually seeing others from the inside. And it's been described as mentalizing in between mindfulness and empathy. So mindfulness is that self-awareness, and then empathy, that other awareness, what taking other people's perspectives. And mentalizing conversations involve thinking about the mental states of self and others. So any conversations about mental health issues should involve an element of mentalizing. And these are the building blocks to like any psychological therapy. Mentalizing is in absolutely every psychological therapy. So it's just being curious, wondering what things are about. So, I mean, demonstrate an example. So if I started crying right now, then I'm not sure what you guys would do. But the first thing that you would probably do is just wonder, wonder what is going on for Dan right now. That's mentalizing. That's it. It's a really kind of simple process, but it's something that we don't necessarily always do well. Okay, and I guess we can maybe have a brief think about how mentalizing can be more difficult at times. So think about kind of COVID-19, and it's forced us all to kind of wear masks when we're interacting with people, or it's forced us to like do online therapy, and I've been doing online therapy since March as well. So that can be harder to attune and harder to kind of to mentalize at times. You don't have the same information to go on. If you're doing stuff online, then you can sometimes have kind of delays. You know what I mean? You don't get true eye contact. And if you are wearing a mask, then you can still get a lot from the eyes, right? You can still get a lot from the eyes, but you don't get the same amount of information as you do if you see a face. I mean, you can't see a smile, and I was going to try and do a smile, but you can't smile because there's fucking no one there. Like, you can't see a smile in the same way. It's not as obvious. Like I said, you can get a lot from the eyes, but it might be harder. You might have to be more explicit about what you're thinking. Right, I've rambled about that, and hopefully I haven't overcomplicated it. So mentalizing is just focusing on mind, not behavior. That's the most important thing, that you're thinking about thoughts and feelings, thinking about mental states and how they contribute to behavior. Now, core conditions, hopefully people have heard of these, Carl Rogers core conditions. He described them as the essential building blocks of any good therapeutic relationship. I would absolutely agree that they need to be in there. So we've got empathy, so taking a person's perspective, try to see the world as they see it, recognizing, understanding those emotions, communicating that understanding back. So I'm understanding this is what you're feeling, checking the accuracy as well. So like saying, am I getting that right? Am I understanding you? Because it's very easy to kind of go off on tangents and actually misunderstand. It's very easy to do. And then acting on that understanding in a therapeutic way. So once you've empathized and understood, then what do you do with that? Being congruent and being genuine. Oh yeah, let me just say about empathy as well. The Brené Brown video, guys might have seen it, but just type into YouTube Brené Brown empathy, and there's a nice, really short video that's really useful around empathy. So connecting with a person's experience, incredibly important. And remember, if you're thinking that people they're just another human being, and you're just trying to connect with that experience and see the world as they see it, remembering that people might see the world differently from you. So congruence, genuineness, that authenticity, so the fit of a person's inner experience to their outer expression, that requires self-awareness, and that walks the boundaries between the personal and professional self. So like, I mean, think about how easy it is for you to spot when you think someone's not necessarily that genuine. We're like, as human beings, we're social animals, so we're actually relatively good, most of us, most of the time, at having those bullshit detectors. So when like, and I remember seeing it in the ward years ago, a woman who, a nurse who had zero empathy for anyone that used substances or anyone that was diagnosed with a personality disorder, and saying to someone, I can't remember what they'd asked for, but she just kind of barked back at them, "I'm sorry, you're just gonna have to wait." Right now, when we're thinking about congruence, right, the words that she said, "I'm sorry, you're just gonna have to wait," there's not necessarily anything terribly wrong with them. Maybe if you're saying you're gonna have to wait, there's a bit of a power kind of dynamic in there. But you can imagine saying, "Oh, listen, I'm really sorry, but you are gonna have to wait because of this, because of that, blah 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 blah." The words that she said did not match the way that she said them. There was zero congruence. The words were saying, "I'm sorry." The outer expression was saying, "Fuck off, I don't respect you," or something like that. It was being really horrible. So think about how genuine you are, yeah, and it can be really subtle as well, and it can be accidental. I think you could potentially come across as kind of as patronizing in a way. I'm going to use this example because it's recent in my memory, but and I don't know if my wife's through there going to be hearing me talking about her, but when kids came to the door on like Halloween, and they're all giving us like these series of really shit jokes, and she was always like, "That was a good one," and like I was just like, oh, just cringing because it was like, no, it wasn't a good joke, and no, you're not congruent with that either. It just didn't feel genuine. So thinking about how you're coming across is really important. And unconditional positive regard. Okay, now that's quite a contentious one. People would sometimes argue that you cannot have an unconditional positive regard, that there's always conditions on it because we are different people with different experiences. So staying out of judgment and accepting who a person is. Accepting the person does not mean accepting their behavior. Recognizing that your own value systems might conflict with that of others. Okay, so think about some things in the world that you might think are abhorrent. Yeah, that's stuff that you absolutely do not approve of, and then imagine working with someone that has done that. Okay, now, like a very obvious example that we often use is paedophilia. Now, it's one of the most kind of horrible things that people can think about. But remember, if you're being a generalist, you're working across environments, you're going to work with a variety of different people. So you might end up working with people that have done things that you really don't agree with and you don't like. So the unconditional positive regard bit, people can contest the unconditional bit. I think I would like to say that it's an ideal. Yeah, it's maybe something to try and strive for. And certainly at the very least to recognize that if you do not have positive regard for people, that you will not have good relationships. Yeah, if you're not able to accept people as they are, and remember that accepting people does not mean accepting their behavior. It might mean trying to make sense of who they are, what they've done in the context of their life experience. Yeah. Recognizing that your own value systems might be different than other people. And again, just kind of to remind you that, you know what I mean, having positive regard for everyone can be really hard. You know what I mean? We are social animals and our values come from this social interaction with other people. You know what I mean? Their values contribute to our laws and I guess our agreed ways of working together. So it's okay if you're feeling something and you're like, fucking hate that thing that they did. That's okay, you're a human. But then if you're wanting to be therapeutic with that person, then you're going to have to try and see them as a person and not forget their behavior, but not just see them as that behavior. Try and make sense of them in the context of their own life. Okay, could talk for hours and hours and hours about that, guys. Okay, but just think about it. Just think about it. Resisting the right and reflex. I'm looking at the time and I say, like, I'm trying to make these things short, but and I say I hate talking to myself in a room, but I must love it. I don't feel like I love it, but I must Must get into it or something. So resisting the righting reflex. So when we see people in distress, there's often a tendency to just want to take it away. And I think it's often really, really well intended, but just trying to fix it for someone can be experienced as really unhelpful. So, I mean, think about how you feel when someone's in distress, and think about, so imagine someone's crying in front of you. Yeah. That can be really uncomfortable for people sometimes. And sometimes the fixing, the trying to make people better is actually about our needs rather than someone else. So often people want to feel understood rather than offered kind of solutions. But there is a tendency to go for the righting reflex. So imagine someone's distressed, crying, for example, and somebody's saying, "Oh, I'm sure it'll get better soon," or suggesting things like, "Oh, have you tried this? Or have you tried that?" Now that's kind of righting reflex stuff, because what you should do before anything else is try and connect and empathize. Yeah. So somebody's crying, then try and ask questions about how they're feeling. Like, I can see you're feeling really awful. Do you want to talk about it? Do you want to tell me more about it? Can you help me understand it? Just being with someone, and caring and showing that you care is really, really important. So listen with empathy before any discussion on solutions. And this, I guess this is where people get confused with it as well. So resisting the righting reflex does not mean avoiding doing things which may help, right? If you absolutely have something that you think will really, really help that person, then you should talk about it. You should offer it. You should think about it. The righting reflex is when that's all we're doing because we're not sure what else to do. Yeah, that we'll just kind of keep trying to fix it. Yeah, have you tried this? Have you tried that? Blah, blah, blah. And actually just connecting with a person's feelings, saying that sounds shit, can be much more helpful. People want to feel understood, not fixed. Okay. Again, there's loads more written about these things. So just kind of planting seeds for you guys to do a bit more thinking. Narrative competence. So I'll read out this quote and then we can make sense of it. So narrative competence refers to a finessed, ethically charged respect for human lived and storied experience. At the level of professional development, it demands that nurses must constantly strive to improve on their abilities around attending, interpreting, and intelligently responding to the stories of people in their care. Okay, so you could think about it as just being able to hear a person's story, hear a person's experience, and help them make sense of it. Okay, so that's going to require open questions, use of silence, and clarification. Now, open questions, clear difference between like, did you sleep well? Yes or no. How did you sleep? Oh, well, I kind of slept all right until 2 a.m, got up for kind of half an hour and then went back to sleep, but overall I slept well. You get much more information from asking open questions. How did that make you feel? Yeah, that's a big kind of nice open question. What was that like for you? Yeah, and actually asking what questions, how questions, more than why questions. Why questions can be quite infuriating for people at times, or imply a bit of judgment, or imply a need for a justification. So whats and hows are normally better. Use of silence, just being able to sit and hear. Yeah, sit and genuinely actively listen. And it's actually a skill, because, and it's probably one of the reasons for the righting reflex as well, is that people feel when they're being silent, either that it's awkward and uncomfortable, or they feel that they need to be doing something. But you can consciously use silence. You know, I mean, I remember hearing a horrific story of trauma earlier this year, and just giving her the space to talk about it. And I think, and this was online as well, you know what I mean? So, and I think I must have honestly been silent for about 15 minutes. Now that's a long silence, but I wasn't disconnected. I was in it. I was very much in that story. I was there with it, but silence was the right thing to do at that moment. And the more silence you give, right? It's not just about silence as laziness, as like, I don't know what to say silence, but if I'm silent, then it gives the person an opportunity to talk through their own stuff themselves. Yeah, instead of just jumping in and interrupting people. And sometimes we'll do that out of nervousness, you know what I mean, out of not knowing what to say next. But just sitting back and giving that person the space to talk is really, really useful. And clarification as well. So that's just checking, right? So you're getting a story, and I mean, I'll use Billy Riddler's example because I quite like it. But talking about, so imagine somebody's telling you a story, or they're telling you how to paint a picture. Yeah, so you're kind of sitting painting something, and then every now and again you're kind of turning it around to them and you're saying like, is that it? And they're like, no, look, ears should be bigger or whatever. You're just checking your understanding of the story. So like that metaphor was with a picture, but you're just checking your understanding of the story. So is that right? Am I getting that right? And being prepared to be wrong as well. It's very, very easy to make really subtle misunderstandings, which can be incredibly important for people. And that's really validating for people to, like, people will allow you to be wrong as long as you sort of label an assumption your own. So if you're saying, right, this is the way I'm making sense of this for you, but is that right? Then people will correct you and they'll be okay with that. But if you say, so what you're feeling is this, then people are not going to like that. People are not going to like you telling them what they're feeling. Yeah. There's a very big difference between saying, so this is what you're feeling, or I'm getting an understanding that you might be feeling things in this way, but is that right? I might be wrong about that. Being really quite tentative, yeah, being that not knowing. Remember being that kind of Socrates, you know what I mean? I don't know your experience, you're the expert. So it can be thought of as making sense, and you can make sense that might link to psychological formulation, which can use psychoeducation models, theory to aid understanding. And personal meaning is paramount as well. And we can think about narrative competence, how this fits with people's spirituality as well. The way that people see the world might be based around that spiritual aspect. Okay, considering the context and environment. So thinking about where you are and how that environment is influencing your conversation with someone. Okay. Now, is that a private space? Is it their space? Yeah. Are you in someone's home, or is it a clinical space that doesn't necessarily feel warm and kind of therapeutic? Does that space shift the power dynamic? You know what I mean? So a person would probably have a lot more power in their own home than they would being at a kind of clinic, you know what I mean, where it's the clinician's environment, their domain. And think about very like obvious examples, or like, so something I used to do as a staff nurse on an acute mental health ward was go and escort people to hospitals. So that are detained under the Mental Health Act. So you would actually show up on people's doorsteps with an ambulance behind you, and have to tell people that they'd been detained under the Mental Health Act and that they had to come into hospital with you. Now think about that environment. Yeah, so uninvited person at your door, ambulance there, detention papers saying that you've got to come into hospital. That's a really threatening environment. So how is that going to influence your conversation? You have to mentalize people. Like, they're going to probably feel really quite scared. They're going to feel threatened. They're going to be in that fight or flight. And you need to be thinking about these things. So you can think about how much the environment is fixed. Can anything be moved? So think about if you're having a conversation, you know what I mean? How do you make a room therapeutic? Is there anything that you can move around? Remembering that you are part of the environment. Okay, so thinking about your posture, your eye contact, your proximity. You are absolutely part of the environment. Yeah. And there's no one size fits all, so it needs to be considered on a person-centered basis. Okay. Thinking about different groups of people that might find proximity quite intimidating. So different cultures. Yeah, I think like social space can be different across different cultures. we have different ways of interacting with people across cultures. Again, like I guess I have to apologize for using all examples about trauma and stuff like that, but it's primarily what I do now clinically. But so I work as a mentalization-based therapist, often with people diagnosed with borderline personality disorder. Often these are young women that have been traumatized by men. So I am part of the environment. So I have to really, really think about that carefully, and actually I have to talk about it with people as well. So I'd often have to say, like, how does it feel being in the room with a man? I know that you've experienced some real horrible stuff in the past with men, and I kind of want to make sure you're okay with that. And really thinking about that then, you know what I mean? Like, how close is too close for me? Really thinking about how does that person feel safe? There's a lot of kind of trauma-informed stuff that you need to be thinking about there. Hope. Right, I hope you guys have been pausing if you need to as well. Feel free to pause at this moment if you want a little rest. We are just about at the end. I think I've maybe got 3-4 slides left, but I think I would love to rattle through these things, but I can't really skip over anything that I think is really, really important. So mental health nurses have been described as eternal agents of hope. I think any person in the helping profession should be hopeful rather than kind of, nobody wants to see somebody that's defeated and has got absolutely no hope for them. So without hope, there can be therapeutic pessimism. And if there is therapeutic pessimism, that can genuinely impact on outcomes. Now, I tell this story a lot, so forgive me if anyone has heard me kind of talk about this before, but I think it's really important. So it was a study in 1968, Rosenthal and Jacobson. So they go into a school and they tell a group of teachers, right, okay, this half of the class are really smart. These guys are gifted. These guys are going places. This half, pretty kind of mediocre, you know what I mean? They're not really going to amount to anything. Now, there was no statistical variation in like the students' achievement rates at the start of the school year. But what happened was that the people that the teachers believed were more gifted did better, not because they were better, but because the teachers had more hope for them. They invested more time and effort in them. Yeah. Now think about people that you might have worked with, people that might have repeated admissions, people that might find difficult to work with in a variety of ways. And then think about how much hope you really have for them. And then just try and think how much of my attitude is maybe getting in the way of this person making progress. Often when people are experiencing mental health issues, they're really struggling for hope. They're really like hopeless at times. So we have to actually carry hope for people when they don't have it for themselves. And I genuinely, like, I don't think there would be any point in us doing what we're doing if we did not believe that people could make positive changes that they need in their lives. So having hope is incredibly important. Having a clear purpose. I'm getting tired now as well, but it's all right. I'll be finished soon and I'll get my lunch. Not that you need to know that. Having a clear purpose. So thinking about when you're having a conversation with someone. So we're like, psychotherapy is just a therapeutic conversation, and therapeutic conversations is something that you guys can do. But think about what you're trying to do. I think that's really important. It's not just a conversation. It's a conversation with a purpose. Yeah. So ask yourself what you're trying to do and why. And can you justify what you're trying to do in terms of therapeutic benefit? But some of those purposes might be really simple, right? It doesn't have to be, I want to change the way this person views the world or change the way they are thinking about themselves. It doesn't have to be as kind of grand as that. It might just be, right now I'm trying to understand. Yeah. It might be right now I'm just trying to communicate empathy. I'm trying to let this person know that I care. Yeah. Yeah, it can be a variety of things. That's based on what do you think that person needs in the moment. Okay, so if you're mentalizing, empathizing, and you're achieving a narrative, yeah, so you're getting that clarified story, that shared sense of what's going on, that can guide you towards further purpose. So the more that you kind of, the more of the story that you develop together, the more of an understanding that you've got, then the more routes you've got to go down. I guess the more opportunities for purpose, for things that you can do together. And you might have an immediate purpose and a longer term purpose. Okay, so some of that helping this person mentalize, help changing the way that they kind of see themselves because they've got a lot of self-loathing or shame or that might be a long-term purpose, but then there might be immediate kind of purposes within that. Okay, therapeutic use of self. Now this is really, really important, and I want you guys to do a bit more exploration into this for yourselves. You know what I mean, to make yourselves kind of better nurses. I'll absolutely blow my own trumpet and recommend my own article that was published in the British Journal of Mental Health Nursing last year, called Self-Disclosure: The Invaluable Grey Area. It talks about how we talk about ourselves with people that we're working with, and that's I think is a reasonably accessible way of thinking about this. But you are a tool with multiple therapeutic purposes. Okay, so you, like, whereas in a lot of physical health care, like you might be using kind of medication, you know what I mean, where the medication is the tool. You might be kind of taking a blood pressure, using a SFIG, that might be the tool. You are the kind of therapeutic conduit, you know what I mean? You are the thing that does it. So you have to really, really think about yourself. You have to be incredibly self-aware, see yourself from the outside, and try and attune to how other people are experiencing you. You need to be congruent and genuine. Okay, if you're like, you can't use yourself and not be genuine. You have to be your genuine true self. And that might use gray areas such as self-disclosure, humor, touch, swearing, for example. Now, the key thing behind therapeutic use of self, yeah, is that it's always for the benefit of the person that you're working with. Okay. So I'm not going to tell someone a big long story about myself just to get my kicks or because I like being listened to. I might share a personal experience that I've had with someone if I think it's going to be therapeutically useful for them, but not just for its own sake. Okay, there has to be a therapeutic purpose. Again, there's having a clear purpose. So if I'm going to be using something myself, then why am I doing this? Yeah. And thinking about why not as well, there's a real taboo around nurses as professionals sharing some bits about themselves with people, but I find it's actually the most important things that we can do is just be human with people, and people will be really grateful for those kind of human moments. So it can be self-disclosure. So self-disclosure is just kind of telling somebody something about yourself that they wouldn't have necessarily known otherwise. Now, there's a bit of self-disclosure that is like natural. So like, I think, so your manner, you're disclosing something about yourself from your manner. Like I wear a wedding ring, so people will know that about me. I'm disclosing that just from my appearance. But then there can be more kind of conscious self-disclosures where you can kind of tell people a bit more about yourself in that as well. Use of humor can be really, really valuable. Touch and swearing, but remembering that these are all person-centered. Okay, now I swear quite a lot, but I don't swear universally across every kind of context. Swearing's quite kind of congruent for me, but I know when I'm in situations where it doesn't feel appropriate, and then I won't do it. In the same way with touch, you know what I mean? Like, there are times where you can think that that's that's maybe appropriate to kind of put a hand on the shoulder, for example. There's times where it just doesn't, it's not feeling right. So you have to tune to the other person and really kind of think about it. But it can be the difference between that being a disconnected co-professional to a connected, understanding human being. And I guess I'll use an example at this point. Apologies, because this is going on for much longer than I thought it would, but there you go. It's education. I'm not shortchanging you guys. I'm giving you all I've got. So working with a guy who was finding it really difficult, kind of like just meeting women and getting into relationships, and speaking about, he was speaking about the kind of Tinder generation, you know what I mean? And I think Tinder is a weird kind of generation. I feel quite grateful I got married kind of before that stuff. Because it's like a catalogue of humans that you can have sex with. It's really quite weird. But he described feeling awkward in that way, in that he didn't feel comfortable. He felt like a kind of an old romantic soul, you know what I mean? He didn't enjoy that kind of going online and meeting people randomly for sex and stuff like that. And I'd used a bit of humor to kind of help him talk about sex. So it described kind of, I was like, yeah. And so I empathized with what he was saying. And then it reminded me of a Chris Rock sketch that I shared with him, where he says like, oh yeah, like anytime a man says kind of anything nice to a woman, you know what I mean? He said, oh, can I get that for you? How about some dick? I mean, oh, can I pick that up for you? How about some dick? And we shared a laugh about that. And I guess what we're laughing about is that sense of him feeling different. You know what I mean? All these guys are out there like hound dogs and stuff like that, and I don't feel like that. And I shared that in myself. I never kind of felt like that as well. I always felt a bit different, a bit of a kind of sort of old school romantic, and not quite like, you know, I mean, I would much rather kind of bring people flowers and stuff rather than kind of like, I don't understand Tinder enough, you know what I mean? I don't need to, but I don't get that bit of it. And just me sharing that bit of myself, essentially what it was doing. So that was me self-disclosing and using humor, okay? But they're both for a purpose, okay? Now, the humor was a bit of like helping it be okay to talk about sex, because he was finding that quite difficult. The self-disclosure was really about normalizing his experience, because often when people are experiencing mental health issues, they feel different, they feel broken, they feel lost. And just him hearing me like essentially went through some similar experiences was really useful for him. And I finished the paper that I wrote by kind of talking about this, because so like we only did kind of 12 sessions MBT, and you can kind of do more, but that felt like enough at that point. And I'd asked him at the end, what was the most important thing that we did? And he said, I think it was just you sharing some of your own experiences, and I knew that like other people had felt the same way. So actually, like, forgetting the model, the finest mentalization that kind of NHS Grampian has to offer, forgetting that, it was just me being a human being and sharing a little bit of myself, sharing a bit of myself with a purpose. That's the important thing as well. Okay. Almost there, guys. Thank you for sticking with me. Or not sticking with me, in which case the opposite of thank you. Okay, so considering timing. So this really comes all back to attunement. So you're a multi-purpose tool. So what purpose is appropriate at the time? So how are you going to use your understandings, your skills, and yourself? Who's doing the right thing at the right time based on your understanding of the person and the situation. Okay, and we do that by attuning. You know what I mean? So I'm thinking about humor, etc. There's going to be moments where it is not right to do humor at this point. This person's feeling really fragile, they're feeling really hurt. It's not right at this moment in time. But if you do something and you get it wrong or run into challenges, then you can have a new understanding. Now, if you're working with someone and there is a misunderstanding and you get it wrong, so imagine I used that story about kind of Chris Rock and that humor, and the guy's like gets pissed off or upset and he's like, I just don't feel like you're understanding me, then I would just apologize. I'd just be genuinely apologize and be like, you know what, I'm really sorry. What I was trying to do was kind of help us sort of talk about sex, but I can appreciate that me sort of saying it in that way maybe made you feel a bit dismissed or whatever. Is that right? I just be real with it, you know what I mean? Just be really kind of apologetic, and then people generally forgive you if you're really sorry. And once you've got that new understanding, then you've got a new approach. Yeah, right. Okay, I know more about this person now. I know more about what's going to work, what's not going to, and you're probably going to have a better relationship for it as well. Okay. Okay, I'm sorry. This it's taken much longer than I thought I would, but hopefully you've got something from it. Here are some takeaway points for you. So generally, people want to feel cared for and understood, right? Now, that's something that we can all do, okay? That's not some kind of mystical thing that is unachievable. Good therapeutic interactions require self-awareness and empathy for others. So that's the mentalizing bit. That's like being self-aware, thinking about, am I having a bad day today? Am I pissed off? Did I not sleep well? Is that like, am I being short with my patients today? Am I being quite abrupt? Having that real self-awareness and then real empathy for other people. I wonder what it's like to be this person right now. Yeah, I wonder what their experience is like. I wonder if I can understand it. The first principle is do no harm. Yeah, like patients experience poor interpersonal skills from nurses every day. And I hear that across the fields of practice. Absolutely. Like I hear about shit mental health care. I hear about shit interactions with adult nurses, children's nurses. This is not something that is kind of unique. You know what I mean? Like across environments, people can have shitty interactions. And I think it's sad because I think the most important thing more than anything is that we do no harm. So we shouldn't be out there doing harm. But then we think about why are we doing harm? And for me, I think it's often because we're not self-aware. We're not really empathizing. We're in busy environments. We're not kind of attuning to people's mental states, or we're scared of having conversations. So don't avoid conversations because you're scared. I mean, imagine how being avoided might feel. Now, it might be scary. You know what I mean? You might feel like you're depth. Oh, I don't know what to say with this person. I'm worried about making it worse. But I can absolutely say if you see someone in distress and you walk away and you hide from it, that will make it worse for them. It will. Whereas if you go into that conversation, you go into that room with that person and say, sorry, I can see you're really upset. Is there anything you want to talk about, or is there any way that I can help? People are going to really appreciate that. They're going to appreciate, at the very least, they're going to appreciate the effort that you've put into it. And it's okay to not know what to say. I had some of my most honest and best interactions with someone that I worked with in a ward where I was overwhelmed and she was overwhelmed, and I shared that. I was like, I don't really know what to do here. I'm struggling to know what to do. And she said the same thing. She was like, I don't really know what to do either. And we actually shared a moment rather than her being pissed off that, oh, fucking expert mental health nurse, what you don't even know what to do. What's the point in you then? She didn't have that experience. She just kind of appreciated that honesty. So there's no one right thing to say. Just try to offer support, empathize, and care. And that same person that I'm talking about, so that was an admission where she was admitted with kind of diagnosis of depression. The admission became quite complicated in terms of interpersonal relationships. She kind of misunderstood staff quite a lot and stuff, and there was a lot of self-harm. It got quite chaotic, and that's why we both felt kind of overwhelmed. But I kept just encouraging her. I was just like, look, just if you're having thoughts of self-harm, just like come and talk to me. And I don't know if I'm gonna be able to fix it, but I'm gonna listen, and we're gonna try and make sense of it together. And at the end of that admission, she gave me a card, And it's the only time I was sort of singled out. Like, I guess it's weird being in a group of people, but then being singled out and getting a card like just yourself as well. But what it said was, I know I wasn't always easy to work with, but I always felt like you cared. And just that like last bit is probably what I've taken with me more than anything. So even like forgetting the mentalization models and stuff, like quite useful things, but she felt like I cared, and that was the most important thing for her. And I guess the flip side of that is that I was singled out for that, and that wasn't necessarily a universal experience for her. She didn't necessarily feel like everybody cared. So I guess it's really, it's quite simple in a lot of ways, but I guess there are complicated reasons that get in the ways of nurses caring and not harming. So please try and be self-aware and empathize with other people's experiences, and try and reconnect with what's going on when you get busy, when you get overwhelmed. Don't let a diagnosis get in the way of seeing a person as a human being. All this stuff. Okay, I feel like I've said enough now, but I don't think I can say enough. I feel like I've said enough because I'm tired talking, but I don't think I could say enough about this because it's people, and these people are important, and this is the most important bit of the job. And no matter what field you are, I think if you're children's nurse, adult nurse, mental health nurse, the stuff that people will remember will be like the way they felt around you. It's not going to be, oh, you did that blood pressure spot on, like that was really good, well done. They're going to remember your manner. They're going to remember how you were with them. So that's the most important thing. And that, I would say, that's nursing. I think we sometimes figure out where our role is in amongst all these other professions. I think that therapeutic relationship bit, that should be ours. But for it to be ours, we need to get that shit right. Okay. Okay, guys, that's definitely enough from me. There's the references there. And thank you very much.